ophthalmology scene is going to go for the next few years. Yeah. So I'm just going to share my screen. I'm just going to do it in a very Singaporean style. So we always have a PowerPoint presentation to start. Let me just kickstart. So let's see. Can I share my screens, please? Yeah, okay, great. Okay, so this new group is called the AI and Digital Innovation Group in SNEC and Severity. So basically, really is established, really it's a very, very young group that we've done. I mean, of course, over the last few years, we've been, doing a lot of AI projects, and we thought if the current trend is actually going to have a major focus in AI digital innovation strategically speaking. This is something that we think is important to do from Singapore. And really the vision of this group is really to see how we could potentially harness the power of the AI and digital technology to enhance really the patient's outcome and experience. So we not only that we want to make sure the outcome is great, but we also want to make sure that the patient experience in the hospital is great using some of these AI and digital technology. So the mission, of course, with the close collaboration with the AI friends like Mike and a lot of others around the world, hopefully we can also be one of the front runners, in the AI and digital innovation scene. And we also want to not just develop the AI algorithm as a research algorithm, but we also want to see how we could potentially implement it in the clinical and the real world setting. And not only that, like commercialization part, I think is something that more and more people are talking about it, and then that in a way also would achieve the sustainability of the technology moving forward with all the startups and spin-off and stuff. And the last point, which is very close to my heart, is to really see how we could actually educate and nurture the next generation, because these guys are going to be the ones seeing our eyes and treating our doing our surgeries and stuff. So so I think they are the very, very important pipeline that we have to actually think about in the whole scheme of things. So this is just the organizational chart. So I mean, the group will be led by myself, supported by Xin-Chi, who is the program coordinator, and advised by people like Tian
I mean, like if when mom comes and talks and all, that won't come.
And as you can see from Seri, that this is a very, very multidisciplinary group supported by different subgroups in Seri, and also again the external partners, both in the technical and the commercial front. And then lastly, we have also the technology development and commercialization to really help us to manage the contract agreements, the IPs, the know-how, and the spin-off and stuff. So yeah, so it's a big team that I'm very thankful to actually work with together for the last few years. And so this is just the profile so far. I mean, so far we've published quite a few papers in different journals, and then we also AI Task Force, and I also had the privilege to join the Imperial College-led Start AI Task Force during my time in London as well. So this is currently some of the ongoing AI and digital technology projects that we are doing, ranging from all the way from ocular to systemic diseases in fundus imaging, OCT imaging, HVF, genetics, and now my group has started looking at the NLPs and some of the digital solutions. We are looking at the patient education applications, the virtual services, as well as the chatbot. And ocular diseases-wise, we actually, the main focus is currently in retina, glaucoma, cornea, myopia. And then, of course, there's more and more projects is coming up in the pipeline. And the systemic diseases-wise, we have published one major papers in NEGM, led by Professor Dan Melia in the Neuro AI in detecting papular edema. We also have the CKD papers published by Dr. Charu in the Lancet Digital Health, and CVD and diabetes is currently in the pipeline. Yep. So I mean, we are currently in the COVID setting. So I think this. I just wanted to take the quote from Sir Winston Churchill. There's something wrong with my screen here, but literally, essentially, he says that we should never let the crisis go to waste. And I think this is a good era and a good time for us to start thinking of how we could potentially digitally transform some of the services that we do. And then the regulators, physicians, patients, public are more likely to accept these new techs. And then moving forward for the next few years, I think there will be more and more. It's anticipated that there's more and more exciting tech is going to get spun out from the ophthalmology scene. So without further ado, so do reach out. I mean, to us. before I go to the next segment. And then this is my email address, and follow us in SFDC Series. We have just set up the new social media platform, link in LinkedIn, Twitter, Facebook, and Instagram. So I would actually get Professor Tian Wong to introduce Professor Mike Chiang for the next segment. Professor Tian Wong, please.
Okay, thanks very much, Dan. Thanks very much to Michael Chiang for really gracing this occasion, and for Dan and his team to set up this webinar. I hope that it'll be a very interesting and very fruitful 1 hour that we have with Michael Chiang. I think Mike is a good friend and really needs no introduction. He's one of the top clinician scientists in the US. And of course, if you look at the CV, it's really what we call blue chip CV, essentially, right? He graduated from Stanford and then Harvard, went to Hopkins, and now he's a Knowles Professor of Ophthalmology and a superb pediatric ophthalmologist. And of course, not just is he doing pediatric ophthalmology as a clinical specialty, his main focus has been on digital innovation, medical informatics, setting up the different registries as well as the big data in the US and into artificial intelligence. I think it is a real recognition of his extensive ability to collaborate, to really get data into real world settings that is going to drive clinical care, that he is now, of course, appointed as the NEI director. And I think we'd like to hopefully be one of the first groups to congratulate him. I'm sure a lot of people in the US have, but from the Asia Pacific, from Singapore, certainly a lot of congratulations. And we are so happy for you. And of course, we in Singapore, in the Asia Pacific, will also support NEI's vision and its mission. And please count on us. In fact, involve us in NEI's mission and its goals. I think NEI, in its foresight, has recognized, of course, therefore, that we moved a lot from the some of the fundamental science to now what is the fourth industrial revolution: medical informatics, big data, and artificial intelligence. And I think Michael Chiang is really poised to lead not just NEI but the world ophthalmology. In the coming really decades, particularly post-COVID, which will be a changed world. So I think without further ado, we'd like to thank once again Mike. This is midnight for him. It's just 10 minutes past midnight for him to spend his very precious time with us. And again, we look forward to hearing from him and to working with him in the future. Thank you very much, Mike.
Well, Tian and Dan, thank you very much for the invitation to come here and speak. And just thanks for all those nice words. One of the things in terms of it being midnight here, we were saying before this started that I go to a lot of meetings with Dan, and on our conference calls, it's almost always midnight or 6 a.m. in Singapore when Dan is on our calls. And so it's nice to reverse that a little bit. But it's, Tian and Dan, I would just say that everything you said, I would say in reverse, that I think that you guys have done some amazing work in Singapore and, set up some amazing collaborations. And I really, look forward to, being able to do more of this in the future. What Dan had asked me to do is to talk about sort of AAO initiatives in artificial intelligence. And let me go ahead. I put some slides together based on that, and I tried to do something to make it a little bit broader. I called it AAO and other initiatives in artificial intelligence, and we'll talk about current directions and future directions. And we always have a disclosure slide. This is my disclosure slide, and most importantly on this slide, I just want to highlight that I'll be presenting some data. Tian and Dan both refer to retinopathy of prematurity. I'll present some information involving ROP as examples of general principles that we'll talk about. And I'll go into all this, but this is a map of some of the people who've contributed to that, and we'll talk about their contributions as we go along. With the topic that Dan asked me to talk about, initiatives, I decided to break this up into a few areas. One of them is going to be sort of what's the big picture in terms of organizational and regulatory activity in artificial intelligence, and I'll focus on what happens in the U.S. because it's really what I'm familiar with. We'll talk about three things: promises, challenges, and solutions. And so really what this is the promises. All of you in Singapore know about the promise of artificial intelligence because in many ways you're inventing that. But what I'll do is I'll focus on some work that we've done in retinopathy of prematurity as a mechanism for identifying some lessons that I've learned about what the promises are and what the problems are that I think need to be solved and are being solved in a lot of ways. We'll talk about some challenges, both from a technical perspective and also from a regulatory perspective. And so I'll go through these, and then I'll talk about the solutions. And when Dan introduced this topic, what is the American Academy of Ophthalmology doing in this area? The reason I'm going to talk about this last in the solutions is going to be, I think, to my mind, the solutions are motivated by what the challenges are. In other words, we're going to try to develop solutions to address, what the gaps in knowledge are with AI. And so we'll go through those one by one. And so this is my first slide. There's an artificial intelligence committee within the American Academy of Ophthalmology. It started as a task force and right now is transitioning to become a committee. And this is a great group of people. This is Dan Ting, and it's Michael Abramoff, Pete Campbell, Pierce Keane, Aaron Lee. These are many of the people that a lot of you in the audience have met or worked with before. And so the task of this committee is basically to define the state of the art in terms of where are we now in artificial intelligence. What are the key unresolved issues and what are the future directions? And so this really focuses on things like research, implementation in the real world, like Dan talked about, how to apply this to clinical care and how to teach the general ophthalmologists and also that next generation of ophthalmologists. And so really the goal of this committee is to help guide ophthalmologists to prepare for that future. Assuming that AI is going to be a big part of that future. Okay, so that's one organizational regulatory body. Another one is there's a group called the Collaborative Community on Ophthalmic Imaging. Okay, this is a group, the CCOI, had its origins with the U.S. FDA, the Food and Drug Administration. Okay, so it's really a regulatory origin. And a few years ago, the FDA convened what they called collaborative communities across all different fields of medicine. And ophthalmology, was one of those collaborative communities. It's one of about 10 collaborative communities. And the purpose of these collaborative communities is to really get the public sector and the private sector, so academia and business, basically, to work together to advance the state of the art. Okay. So really, how do you operationalize technologies and get through regulatory approval and get them used in the real world? Okay, so the goal here is to clarify. So this is really a regulatory and kind of a road mapping body. So the goal here: clarify challenges, identify best practices, identify strategies for how to get there, and identify standards. Where do we need standards? For example, things like data transmission. Okay, so these are some of the folks on the organizing committee for one of the FDA collaborative community meetings that's coming up. Actually, it's a week from today, a virtual meeting. Yeah, I can give the details if anybody's interested. But so that's the second organizational regulatory body in the U.S. Really done through the FDA. The third one that I want to talk about is through the National Eye Institute. And there's a strategic planning group in data science that's going on right now. And so this one is a little bit more focused on research and infrastructure building. And so the goal of this strategic planning task force basically is to identify key advances and opportunities. And there's actually a National Eye Institute-wide a strategic planning process that's going on now. And this panel in data science, now it turns out, just so you all know, there are 7 such panels through the National Eye Institute. Data science is one of them, and another one is something like genetics, visual neuroscience, and so that really gives a sense of how far data science has come during the past few years. Examples of what this focuses on: big data, artificial intelligence, training and education, and also computational advances. And so this group is sort of a combination of clinicians and scientists across vision research. Okay, so 3 groups: one through the American Academy of Ophthalmology, one through the Food and Drug Administration in the U.S., and one through the National Eye Institute that we'll come back and talk about toward the end. Okay, so that's sort of the overall landscape here. So at this point, I want to talk about what we've called some of the challenges, some of the promises. And again, we'll use ROP as an example. Now, assuming you're one of the 95% of people in this audience who's not interested in ROP, what I'll try to do is to focus on general principles here that can be applicable to any disease. So the one thing I want to start with about ROP is disease classification. You've got to have standards for how to talk about things. If you're going to do clinical research or do artificial intelligence, for that matter, and I think it's a big gap that a lot of diseases don't have standardization in terms of how we do things or how we call things, even. And this was developed in ROP in 1984. Okay, so it's been decades that, in theory, everybody in the world uses the exact same terminology: zone, stage, clock hour, extent, and plus disease to describe findings. And that is a huge benefit in terms of clinical care and clinical research. Now, I would actually point out, as a Singapore connection, that there is a revision of the ICROP, the International Classification of ROP. The first one was 1984, the second was 2005, and the third one is being sort of spearheaded by a group called IPOSC, which is the International Pediatric Ophthalmology and Street Business Council, that was headed by somebody who many of you know, Sonal Farzabandi, so right here in Singapore. Okay, so there's a nice Singapore connection with ROP care. So there's been a number of NIH-funded clinical trials based on this classification. So everybody speaks the same language. You do these multi-center trials. And from those trials, we know that of all these different parameters, plus disease is the most critical one for identifying when a baby is at risk for going blind and when they need to be treated. Okay, so what's plus disease? It means tortuosity of the arteries and dilation of the veins in the central retina. Okay, so remember those terms: tortuous arteries, dilated veins in the central retina. Babies at risk for going blind, you need to treat that baby, so we've got to diagnose plus disease accurately. Okay, so one point that I want to make from this is that there's a problem that clinicians are not very good at agreeing on plus disease diagnosis. Okay, 13 years ago, we published an embarrassingly basic paper, which is that we put images on the web of various retinas and asked world experts, 22 world experts, is this plus, pre-plus, or normal? Okay, and the results were that they often split. Here's an image. There's a little bit of tortuosity, a little bit of dilation, and 50% called this plus, 50% called it not plus. And there were a lot of images that split 50-50, 60-40, or 70-30. So this is a big problem. That even the world experts do not agree on the diagnosis. Okay, often subjective and qualitative. Another issue is that we often have disagreement in process. Okay, and so for this, I want to talk about a little bit of what I'll call science and art in medicine, because I think this is also a very generalizable principle. If I could back up here, I would say that disagreement in diagnosis is generalizable. Okay, ask two different glaucoma specialists, how do you diagnose glaucoma? What's the cup to disc ratio? Does the cup to disc ratio matter? You'll get a lot of different answers. And process, exact same. I was on an ROP panel 7 or 8 years ago, and one of the experts on the panel said, plus disease is like one of the U.S. Supreme Court justices in the 1960s described pornography as being. He said, quote, I can't define it, but I know it when I see it because it just looks bad. Okay? And I thought about that comment for months afterwards, and it really bothered me because if we want to be scientific about things, how can we just be saying that things just look bad? It seems really vague. But on the other hand, every clinician knows that there's a such thing. This retina looks angry, or I just don't like the way this patient looks. This makes me nervous. And so we got to thinking, could variability in the diagnostic process explain some of the variability in diagnosis that we're seeing on the previous slide? In other words, if different people have different concepts of what makes them just feel bad about things, could that be a problem? And so what we did is that we gathered who we thought were the 7 most seasoned ROP experts in the world. Okay, these were people who originally came up with that definition of plus disease, came up with that international classification system of ROP back in 1984. And we gave them a set. We spent months identifying a standard set of images to show them. We scripted questions for them, and we videotaped them. And we asked, okay, you look at this image, and you tell us what makes you worried or reassured, and you annotate areas on the image that make you sort of worried or reassured. We videotaped it, and we had a cognitive psychologist go back and analyze hours of videotaped transcript to try to model their thought process. And so here's an example. This is one image, and expert number 1 called it plus disease. Expert number 2 called it pre-plus disease. Expert number 3 called it normal. Okay, so and the other thing is that they're all looking at different parts of the retina. Okay, so I think that this is probably a very broad and generalizable fact that there's difference in diagnostic process as well as difference in diagnosis. And look at the glaucoma example, and I would argue that this is generalizable. Some people pay attention to nerve fiber layer thickness, OCT. Some people look at the optic disc. Some people look at the eye pressure. And so I would argue that this is probably a generalizable principle. So Nina Hewing, postdoc with us, wrote a really neat paper about this, years ago. So when you get different experts to look at different images, so here's expert 1 to 8 over here, 100 images. There's some interesting stuff that comes out. And so the way to read this is that each expert diagnoses each image as plus, pre-plus, or normal. If they diagnose that image as plus, it's in red. If they diagnose that image in pre-plus, it's in yellow. And if they diagnose it normal, it's in green. Okay. So the first thing to notice is that experts number 7 and 8 down here on the bottom diagnose plus disease 6 times more often than expert number 1. Okay. And if you go to a different data set, this is a different data set of 34 images, it's that exact same 6-to-1 ratio. Okay, same experts, different images. You've got these overcallers here, and you've got these undercallers here. Okay, and again, I would argue that this is a generalizable principle. We all know that this exists. There are some docs who are always going to operate, and there are some docs who are always going to observe or use medical management. And this is what it looks like on a grid over here. And the other thing is that if for every image going down the columns here, if you calculate a score for that image, so give that image 1 point for normal, 2 points for pre-plus, 3 points for plus. And if you calculate the average and you convert it to a color, that's what it looks like here on a spectrum. Okay, so down here, these images are very, very green because everybody diagnosed normal. Okay, over here, they're very, very red because everybody diagnosed plus. And here, you've got every color in between. Okay, so the point that I want to make from this is that the real world is a continuous spectrum of abnormality. And evidence-based practice makes it sound like patients come in buckets. Normal, mild, moderate, severe, but we don't. Okay, there's everybody comes along the spectrum, and when the challenge is that I think that we've actually shown data that I'll show on the next slide that doctors are very good if they're presented two images and asked to identify which is better, number one or number two, which is more severe disease. But we're not very good at drawing lines. Okay, so cutoffs. Okay, some people will draw the cutoff here between plus and pre-plus. Some will draw it over here, and really that is where I think these artificial intelligence systems can help. Okay, and Pete Campbell wrote a really nice paper on these principles in ophthalmology a few years ago. And this paper, this image comes from a paper that we worked on with Jayashri Kalpathy-Kramer on this issue of classification. In other words, binning, mild, moderate, severe, versus comparison, which is worse, number one or number two. And so the point here is that when you ask experts, numbers 1 through 8, is it plus, pre-plus, or normal? And the darker the color is, the higher the kappa, the correlation is, between two different experts. Not very good correlation at all between these 8 world experts. If you ask them which image is more severe, number 1 or number 2, these are correlation coefficients, very good correlation between experts. And so we're really good at comparing and looking at relative severity, but we're not so good at classifying. In other words, are you plus, pre-plus, or normal? Are you mild diabetic retinopathy, moderate diabetic, severe? That's an area where we need help. And you get 5 different experts to rank 100 images in order from most severe to least severe. Actually, very good correlation in that rank ordering. Okay, so I think that's something that we'll come back to because we want to take advantage of this. And one thing that we've gotten interested in is developing deep learning-based vascular severity scales. So you take that output of these deep learning systems that we develop, and we convert them to a 1 to 9 scale. And so we've done work building systems like all of you have in Singapore. You've done some beautiful work in across many diseases. We do this for ROP, and we've shown that you can do a very nice job of separating plus disease versus pre-plus versus normal. And we've got as a disclosure, we've got a system that's received breakthrough status from the FDA in the U.S. To do this. And what we've been working on more recently is taking the output of that system, okay, probability of plus, probability of pre-plus, probability of normal, and convert it to a 9-level scale. Okay, so in other words, we're going from qualitative to quantitative. And so why would we want a 9-level scale? Right now we've got sort of a 3-level scale in some ways, plus, pre-plus, normal. And we've got a different 5-level scale for stage, okay, stage 1, 2, 3, 4, 5 in ROP. And so for plus disease, why do we want to go from plus, pre-plus, normal to a 9-level scale? One of the issues is that, from a clinical rationale, I give a lot of talks, and there's always some people in the audience who say, well, I don't want a computer system to tell me plus, pre-plus, or normal because there's a medical legal liability if the computer system says one thing and if I don't follow it. Now, I don't necessarily agree with that, but I've heard it so many times. And one of the rationales behind this type of scale is that the AI system would give the clinician a piece of data. What's your severity from 1 to 9? And the doctor then decides what to do with it. Okay, so so it's data instead of diagnosis. It's like a blood pressure, and the doctor diagnoses hypertension. The machine gives you a number, getting 140 over 90. From a clinical rationale, why do we want a 1 to 9 scale? Because if there's really this continuous spectrum of abnormality, maybe that 3-level scale isn't granular enough. And on a day-to-day or week-to-week exam, you really want to know, is my baby better, worse, or the same compared to last week? And a 9-level scale just gives you more granularity to figure that out. Okay? And from an experimental rationale, what we've shown is that we're better at comparisons. Okay, are you better or worse, number 1, compared to number 2? And if we have a scale with standard images for each of the numbers here, maybe clinicians can just compare, well, where does my image fit on the scale from 1 to 9? Okay, so that's the rationale for why we want to go from qualitative to quantitative using deep learning type methods. And so can we use these methods for disease screening? Okay, so what we've done here is that, of course, we can take these systems and give a diagnosis, okay, plus, pre, plus, normal. But in this case, what we're doing is that we're converting that to a scale from 1 to 9. And, can we use this if we're out in the field screening for disease? Okay, so, Travis Redd, who's a junior faculty member in Oregon, did a study, about a year ago where, took, almost 5,000 images and calculated one of those deep learning vascular severity scales from 1 to 9. And let's say we're out in the field screening. And we used 3 as a hypothetical screening cutoff. Okay, if you're 1 or 2, you don't get referred, but if you're 3 or above, you get referred. We'd have sensitivity 94%, specificity 79% for identifying treatment-requiring disease. Increase that to a 5 out of 9 for the screening cutoff, your sensitivity goes down, but your specificity goes up. So could these types of methods be used as an assistive device or in resource-poor settings for doing disease screening? And the other thing that we've explored a little bit is that Stan Taylor was a retina fellow with us last year, and could this quantitative deep learning scale be used to look at disease progression and disease prediction? So here, the thing about ROP is that we do the initial screening exam at 30 to 32 weeks post-menstrual age. And usually, so we examine every 1 to 2 weeks. And, when babies get to 38 to 40 weeks post-menstrual age, and this area is usually when they need to be treated for disease. In other words, when they develop disease, it's bad enough that it needs to be treated. For those, most babies never do, but for the ones who do, it's around this time point. And so these 2 cohorts are basically, of these 5,000 some babies, the babies in white never needed treatment. Okay, this was the majority of the babies. The babies in blue needed treatment at some point. But you'll notice on the initial exam, they basically had the same 1 to 9 vascular severity score, this quantitative deep learning score. As you progress on subsequent exams, by the 2nd or 3rd time point, the babies who were meant to develop treatment-requiring disease, they've already started to diverge, okay, even though they didn't get severe enough disease until this time point to need treatment. Okay, so the question here is that could these quantitative methods, based on deep learning, be used to predict risk and identify babies at risk for progression? Okay, so I think that there's a lot of potential to this. Okay, so that's what we'll call the promises. Okay, what are some of the things that we can do using artificial intelligence that can really change the way that we practice? So I want to talk about a couple of things here about why this is difficult. And some of this is going to focus on electronic infrastructures for healthcare. But some very generic challenges for AI, and these are the things that all of you have thought about before. But I want to try to put them into one position here, one place. One of them is that these systems can't handle what they weren't trained for. These systems, Michael Abramoff's system, IDX. It's very good at diagnosing diabetic retinopathy, but if you give it a central vein occlusion, it doesn't know what to do. Okay, so system accuracy is better depending as the system task gets more narrow. Okay, the challenge here is that we as experts, we don't just diagnose diabetic retinopathy, we diagnose disease. And how do you develop standards for integrating multiple systems? Okay, big unanswered question to my mind. We're getting better. One thing important is to be sure all populations are represented in developing models. Okay, so developing systems for glaucoma, and we know in the U.S. that in the Black population there's higher risk for glaucoma. Now, how do you know your system's not learning the pigmentation instead of learning the disease? Okay, so I think that one of the challenges is to make sure all these populations are represented to make sure that we're not learning things that aren't really the key factors here. Of course, we need to have large, well-curated data sets, training sets, and this is something that Tian and I and Dan have talked about at length before. You've got to have accurate gold standards. What do we do if the gold standards evolve over time, and how do we keep up with that? I think that there are huge questions involving whether black boxes are going to be acceptable to clinicians. This is something that Dan and I have talked about a lot, and maybe we'll talk about in the discussion here with Tian. Is explainability of these AI systems required for physicians to trust them? Do doctors understand these technologies, and how is this going to evolve over time? And what can we do to help people evolve their knowledge over time? Big questions. And I think another issue is that you've all heard the phrase garbage in, garbage out, and these systems require adequate image quality. How do you assess image quality, and who's responsible if the image comes into the system? So here you've got a good quality image, a possibly good quality image, and a not so good quality image. Who does that screening, and who's responsible if there's a mistake? Dan alluded to the question of real-world systems. Should these systems be used to screen for disease? Should they diagnose them? Who manages this? Is it the ophthalmologists? Is it the optometrists? Is it the primary care doctor? And really, who owns these services? And so a lot of these you've all thought about before. I want to focus on one other thing that's potentially not thought of quite that often, which is how does technology affect the practice of ophthalmology? This has become a big problem in the U.S. Doctors are complaining that electronic systems are time-consuming. And the electronic health record, or EHR notes in the States have become much longer than paper notes. The old-time docs will say that in the old days, paper notes were just one page, and they had all the information pretty concise. But now they're getting really long. One of our residents took a page of an average note for me one day. It was 8 pages, for a single eye exam visit. And how come they're so long? Doctors are copying information, because you've got it pre-populated from the previous exam. They're just copying forward. The challenge is that our docs can't tell, did something really happen that day, or did somebody just copy it forward, from the previous visits? We're using words and not pictures for representation. In the old days, well, let me just sort of use this as an example. Every physician who's above the age of 40, in the U.S. knows what this means. And it's been 25 years since I worked up an internal medicine patient during my internship, and I can still look at this and more or less know what it means, because there's something about that visual representation that formed neural connections for me. And our younger trainees don't use this. They use columns of data where all the columns are different. Some computer systems, it's electronic. Some of it's sodium, potassium chloride, bicarb. And so are they developing the same neural connections that we used to develop? Who knows? But I think this is an important question for people who are using more and more electronic systems. And one of the things that we've gotten interested in is using data and analytic methods to study, well, how are doctors using electronic systems? And so recently, a couple people, Brad Henriksen, Michelle Rybar, Adam Rahul, are some postdocs and faculty within the group at Oregon, our group, if you will, who looked at things like length and redundancy of electronic health record notes. These were almost 3 million EHR notes in Oregon, from over 6,000 doctors across all different specialties over a 10-year period. And we looked at things like how long is the note, how did the information get there? Did somebody type it in? Did they copy paste it from the previous note? Did they use some template, for pre-populating? And we've used sequence alignment algorithms, compare one note to another and figure out how much was redundant. And the bottom line here is that notes are really long. They're 2 to 6 pages on the average, and the content is heavily redundant. okay, 45 to 75% word for word, okay, from one note to the next note. And I think one of the challenges here, and it's also getting worse over time. This is 2009, this is 2018. So this is what we are seeing in the US. And the challenge here is, how much unique content is there? Well, for us, most of it's redundant. And what is the implication for artificial intelligence systems? We work with this project Iris Registry through the American Academy of Ophthalmology, and people were talking about making word clouds for what words were used most commonly, or to identify what was repeated. If people are copying the same thing over and over every exam, I think this is a big problem for for AI systems. So along the lines of, we've got to have good data. Okay, and so I'm just going to finish up with an anecdote here. About technology and cognition. So I think this is really important. I used to work in New York City before I moved to Oregon, and there was someone, Vimla Patel, who was a cognitive psychologist who became an informatician. And this is a set of her work that I thought was fascinating. So this is the premise of this is that her group studied an internist in Canada who had was using paper charts. Okay, they were just sort of documenting the old style way. And so Vimla Patel goes to the doctor's clinic, gives them a piece of paper, and says, "Can you work up a patient and write me a note?" Okay, so here's the note. Okay, 74-year-old woman, diagnosis of diabetes made in February, polyuria, nocturia. She had an eye exam, normal retina. And so this is what all of us learn to do in medical school. You take a narrative history and you tell a story. It's all qualitative, right? So part 2 of the experiment is that the system, that practice converted to electronic health records. Okay, so point and click, you type in what you've got. And so part 2 of the experiment is that Vimla Patel goes to that clinic, ask the patient, ask the doctor, work up a patient, use your EHR system, write me a note. Okay, here's what that note looked like. Okay, completely different. This is not narrative text anymore; it's structured documentation, and this is what we've seen in the U.S. for the past 15 years in Oregon. Structured documentation instead of narrative text. Okay, so the structure, the method of documentation is changing. Part 3 of the experiment is that this doctor gets used to using EHRs. Okay, and so later, Vimla Patel's team goes back, gives them a piece of paper, and says, "Work up this patient, write me a note, and here's what it looked like." Okay, on a piece of paper. So I thought this was fascinating because the technologies that we give people to use to do their work affects the way that they organize information. Okay, so it's not. I think it's not just about does it take longer? Does it is it 2 pages, or is it 6 pages, or is it 1 page? Are you diagnosing by just looking qualitatively, or are you doing OCT? Are you doing artificial intelligence on OCT? All these tools that we give to clinicians affect the way they process information. And I think that's really, really important for a group here that's considering the impact of technology on the practice of ophthalmology. And so, we talk about our system's going to replace doctors. You all have talked about this a million times before. I'm going to argue that we do 2 things. We diagnose disease and we manage disease. And when we diagnose disease, what's wrong with you? What disease do you have? I think AI systems are really promising, but where are we going to get the data to make a diagnosis? Someone's got to ask that question. They've got to have judgment, and they've got to interact with patients to get that data. When we manage disease, you've got this diagnosis. Am I going to operate on you? Am I going to give you medical management, observation? For that, we've got to understand patient preferences and risk-benefit trade-offs. And how do you do that? You get to know your patient. Okay, and so what I want to emphasize here is that in the era of evidence-based practice, the electronic health records, and best practice guidelines, we all believe in this stuff. But I think that there's a potential loss of clinical judgment and ability to interact with patients. And I feel like we're seeing that in the U.S. And I'll be curious what your impressions are in Singapore. But if the goal of these systems is to improve clinicians and it's to improve diagnosis, it's going to be really important to maintain these uniquely human skills that help us better manage disease, so that we don't get made obsolete, and that we can actually use these systems to help us, do the things that we can really focus on. Okay, so diagnosis and management, and I think this is really important. So I'm just going to finish up here with what are the key issues that we're looking at, because as you can tell, I've tried to work up from these challenges to what the key issues are, and these are really the task of the AAO's Artificial Intelligence Committee, the FDA's collaborative communities, and also the National Eye Institute's roadmap for the future. So it's going to focus on addressing those challenges that we just talked about. So, from a clinical practice perspective, how should the average ophthalmologist understand the AI literature and interpret the output of that? Well, Dan and Tian wrote a beautiful editorial, 6 months or so ago in Ophthalmology about this, and that, and beyond this, what are the benefits and limitations of these systems? How important is explainability? What are the accuracy cutoffs for acceptable performance? I think those are unanswered questions in a lot of ways. And from a clinical research perspective, there's a lot of research going on. Well, how do we separate good research from not so good research? Dan has done some beautiful work with these starred AI consortia. Pierce Keen, Aaron Lee have done some nice work with other consortia. How do you develop ideal reference standards? What should that reference standard be? Is it one doctor enough? Probably not. Should it be multiple doctors? What constitutes a reference standard? Is it one image? Is it a full eye exam? Or do we need longer term outcomes? Do we need randomized controlled trials using artificial intelligence? Okay, so we're going to have to figure those things out. Okay, we talked about this issue from a systems perspective. Okay, how do we integrate multiple narrowly focused AI systems? Okay, how do we make these AI systems interoperable with electronic health record systems? Where doctors usually work. In the U.S., the American College of Radiology has done some nice work in trying to integrate multiple systems. So we've got to start doing this in ophthalmology, I think. Lastly, from an ethics standpoint, what are the medical legal liabilities? What are the privacy concerns about big data? Are there concerns about academic industry relationships? Google has obviously become one of the big players here, and is that a good thing or is that a bad thing? We talked about infrastructure. How do we develop training and validation data sets? How can for example, the U.S. and Singapore and other people collaborate to develop those data sets? What should those data sets consist of? And from a training perspective, what skills are going to be required for doctors to do this now and in the future? How do we ensure that clinical skills are not lost along the lines of what we talked about? And how do we develop curricula? Okay, so I think that in summary, this is a real, I've tried to give an overview starting from organizational regulatory bodies, going from promises and challenges. And I think this is how I see, the roadmap for, what is the AAO doing? What is, and what are groups like the FDA doing with this? And, with that, I'm going to stop and just say that I think that we talked about concepts of, science, technology, and art. And, I just want to leave and finish by saying that I think good practice requires all of them. Okay, science, technology, and art. And one of our challenges is how do we integrate all of those? So Tian, Dan, thank you very much for the opportunity to, just present this here.
Mike, thanks very much. I think a really very comprehensive and thoughtful discussion, and I think maybe for the audience, you can see that it is really not like one disease, one paper, one technology, but it really is going to change really the profession and how we practice. That needs to be looking at integration with big systems, not only in ophthalmology, but the bigger ecosystem. and likely can't be done in a single country and maybe globally as well. So many challenges. So I think it's a very exciting time for people, hopefully on this call, to to really understand that in the next 10, 20 years, this is going to be something that we're going to be dealing with, and we have to be very comfortable with it, as well as to really understand not just the questions, but I think many groups is going to have to look at different answers. It's not going to be simple to solve. So I think once again, thanks very much, Mike, for sharing this very nice roadmap. I'm sure as NEI director, you will be full of challenges, looking at trying to institute some of those solutions to the questions that you posed, essentially. So I'm going to pass it back to Dan to maybe open this up for some question and answers, essentially.
Thanks, Mike and Tian. Mike, it's always like there's so much to learn from just listening to the talks. There's so many talks that I've attended, and yeah, it's very, very enlightening. And I can't agree more with a lot of the challenges that you have brought up, especially in the second half of the presentation. So, I mean, I could actually, Wei Boon is also one of the cornea consultants in SNEC, has actually raised the questions about, with regards to the ROP study where experts graded ROP photos, did it include other data points? For example, the age, the gender, medical problems, and etc. I wonder if concordance amongst the experts would have been higher if the history and background were included. So perhaps, Mike, you could actually, share some thoughts on this.
Wei Boon, I think that's a great question. And let me try to answer that I'll obviously answer what we did, and then I will try to give some of my own thoughts about alternative ways of doing it, and then some questions about things where we could be going in the future. And then I want to ask the same question to Dan in terms of how Dan and Tian think about this. So, Wei Boon, to answer your question about ROP studies, we just had experts look at photos and no other information besides that. And the reason that we did that was that in theory for ROP, things like plus disease are diagnosed purely based on exam at a single point in time. And they're based purely on the morphology, not based on the age, risk factors, other things. So it's the definition is that it's truly morphological. That was the reason that we did it. And we thought, well, let's just focus on the morphology instead of those other risk factors, in a Bayesian, kind of way. Now, having said that, Wei Boon, I think that in the real world, we not always, but ideally should know those other things about babies or about any patient we examine. We don't just start examining a patient; we know something about them. And so, I think that personally, an ideal to stimulate more real world, we would know something about the patient. Now that makes it much more complicated to study. Going one step further, one of the things that we know in the real world when we see patients, whatever the disease is, usually is how did my patient look today compared to what they looked like last time? In other words, that delta. And those deltas, I think that we're very good at building systems that diagnose at a single point in time. But sometimes the more important factor is how did you look compared to where you were, and are you getting worse? So that puts you in a different category. And that's something that we're interested in building risk models for, but we haven't really gotten there yet. And so what I see as being sort of the future of this type of work is moving from where you are right now to let me predict what you're going to be like next next year, or how are you doing compared to what you were last time, and what implication does that have for the trajectory of your disease? And so I'm going to stop there. And Dan, I would love to hear how you're addressing all these sorts of issues, like going from point in time to risk modeling to prediction to modeling deltas and those, because I think that's what I personally see as important.
Yeah, thanks, Mike. I can't agree more. And just to give a very short response to that, I think what Wei-Bun has alluded to is actually a very important question, especially when we're trying to develop the predictive modeling. So, I mean, for the cross-sectional modeling, it plays a slightly of a less important role in terms of doing like a disease detection, because it's mainly it's really like an image-based the answers, rather than taking into account a lot of risk profiles. So when we precision medicine, on the other hand, I think all these the risk factors to predict the disease progression, who's like going to develop the PLAS, or who's going to have a rush ROPs and stuff. I think that is when all the age and gender and stuff will start coming into place. Ken, what do you think?
I think there are these are very good challenges, right? And the current state of the art is, as Mike has said, and many of you are aware of, number one, a single time point, usually single modality, in other words, an image or an OCT scan. And what we have learned is that there are maybe three things that we are still thinking about and researching. One is changes over time, right, which Mike alluded to, and the systems and the I would say even the computational scientists and the technical experts have not been able to map out changes and that delta over time as accurately as humans and physicians. So we can see it, and we can see someone at baseline and 1 month or at 1 year, and we can make a judgment very quickly whether the disease is stable or has progressed or has not. I think the artificial intelligence technology has not been able to do this, and I think part of it is the data set, part of it is how do they track features, how do they map features, and how do they think. We have not addressed the longitudinal chain. The second point, which Wei-Bun has alluded to, is how do you put the additional information into this learning process? And when we see, a photo, we are sometimes not as confident as seeing a person, because a patient that is poorly controlled, that has all sorts of social, economic, even personal issues, with a fundus photo of this stage of diabetic retinopathy is managed differently from someone who you could be quite confident that maybe they are going to either get their control better and they're going to come back on follow-up and so forth. So basically what I'm saying is that the physicians take in inputs that are not taken in simultaneously, right? The age, the gender, the race, the systemic effect, and so forth, what Wei-Bun is alluding to, essentially. And none of the AI technology has put in the subconscious input that physicians do when they interact with patients or when they see patients, which is why I think physicians are very worried all the time whenever they're saying, I want you to grade 100 photos, because they're not that confident. But if they're seeing, I would say, 100 patients, they're more confident about diagnosis, essentially. So I think that this part here is something that really AI not addressed, and I think we need to look at that. And then I think the third and very probably important aspect, which Mike has also alluded to, is what is the gold standard? It's the gold standard agreement, which is exactly what we're doing. So in other words, we think that an agreement that is as close to or better than human agreements, if a human agreement is 0.8 and the machine agreement is better, then maybe that's the gold standard. But that's not really disease standard, essentially. And I think that that's one of the biggest challenge for ophthalmology as well. We are just looking at patterns. Now, there are some that's quite obvious, right? So if you have very severe, let's say, neovascular AMD, you know that it's bad prognosis. It's nothing to talk about. But there are many different stages of disease that are in between. I think the ROP staging 1 to 9, how do you know that 6 is going to be better than the 8, or 7 is worse than 3. I mean, these are all very judgmental things. I think having that gold standard has not been well addressed in this. So I think that the challenges for AI and big data going forward, and I alluded to many things, are some of these elements that we have not addressed, and really a lot of research in this area.
Yeah, Tian, I think those are great points. And if I can just follow up on one of them, which is that we all learn things like neovascularization elsewhere is bad in diabetic retinopathy, and plus disease, meaning tortuosity of the arteries and dilation of it, is bad in ROP. And it took me a while to realize that, our residents think that these things got invented in textbooks. But, where, of course, they really got invented is that experts decades ago anecdotally felt that these things were bad. Clinical trials were developed to test those hypotheses. They were shown to work, and now we're stuck in the mindset of you look for NV, you look for dilation of the arteries, and I actually hope that in some ways AI can help us move to first principles and just try to identify, well, is it really NV that is what makes it a 9 out of 9? Or is it something else that we don't know? And that may be something, because I think that's one factor. Are there going to be better ways based on real data? The second issue, Tian, which I think you're getting at, is that a lot of times we're stuck with the framework that we were given 40 years ago with classifying disease. And nobody gets past neovascularization of the disc because they're all treated. And so a lot of times these things were developed based on natural history studies looking at the outcomes. So they were outcome based. And I think one of the challenges that I've been struggling with, and I would love, to figure something out together, or is how are we going to approximate that? Or do we need to do those studies? Or is it going to be, because right now we're stuck with expert consensus in a lot of ways, as you said, and expert consensus is kind of flawed because it's tied to what we all learned in school, which was based on these clinical trials. So there's a little bit of innate circularity to this. And so I think that there are going to be some challenges to how can we really expand the scope of what we're able to do to take the best care of people.
Yeah, maybe Mike, I might go to address part of that. We've been thinking a lot along these lines. ROP is one example, but diabetic retinopathy is the other. For example, if we have, and we certainly have, one of our system basically grades retinopathy on a severity of 0 to 1, right? I mean, that's what they do. But how do you translate that to the current, ETDRS grading, and how do you replace that grading, and will it be acceptable to to ophthalmologists or the senior retinal specialists who's been treating diabetic retina for years that's used ETDRS and so forth? How are you going to do that, right? And I think the only way is really, as you said, evidence and data. Now, we're not so good at doing this. I think a lot of the landmark studies managed to do this when time was, you can say, when there were fewer challenges, when it's easier to do 5, 10, 15-year longitudinal studies. And, many people are not willing and really worried about trying to do some of those kind of work, essentially, right? I mean, like the Wisconsin study that the Kleins did in the 80s, right? It won't be replicated today. In fact, I mean, maybe that's one of the things that you'll be asked to think about in NEI. I mean, how do you fund studies that are going to be such a long tail? Because that's what exactly you're going to be looking at. Is the ROP stages now predictive of vision loss when they are 20, right? When they're 20-year-old, and how do you link that? I think the big data part of it may offer some hope. I think, the IRIS registries and others, whereby if you're able to confidently link outcomes or treatment outcomes, and, even more importantly, not our current measurement, which is really visual acuity or loss of vision, but quality of life, patient-related outcomes, and you're able to demonstrably show that the new scheme, whether it's called 0, 1 to 9 in ROP or 0 to 5 or whatever it is predictive of clear-cut patient-related outcomes 5 years down the road, then I think physicians might say, yeah, it's about time to move on from the current classification. Then I think that you don't depend on just expert consensus. I mean, at the moment, I'm seeing a lot of papers in ophthalmology on AMD based on, and diabetic retinopathy for that matter, right? Based on expert consensus. We think that this lesion represents this, and therefore it's more severe and so forth. Because we don't have those long cohort observational studies anymore. I think that's going to be quite important over time.
Yeah, just to tap on that, I think some of the classification system and the reference standard that we've been using for the past 50 years, it may actually change over the next 30 to 40 years, right? I mean, right now, we are talking about outcome based, for instance, like DR and stuff. Those are outcome based stuff that Michael Abramoff always like to say. Hey, what's the gold standard for US FDA to pitch any AI algorithms that's been submitted to for regulatory approvals and stuff. But again, how costly is that to actually conduct a prospective clinical trials? And I'm sure Mike will probably chime in on there, how expensive it is to actually conduct a prospective clinical trial for ROPs to test out the AI algorithms. And those are the things that I think is still currently remain as a moving targets and stuff. And I think that will actually really, I'm quite excited to see what the field is is going to do about this for the next moving forward. Yeah. And I just saw another questions about Wei Yan has posted questions about generalizability. So Mike, questions to you is that if AI system is trained based on a certain reference standard, certain imaging modality, and if you were to transfer or use these specific AI algorithms on another image taken by another camera, how do one go about this?
Yeah, Wei Yan, that's a great question. And I'm sure that everybody here knows that, if you take a measurement with one OCT machine and a different OCT machine, they won't give you the same numbers. And this is a huge problem. And I think that everyone here knows that there's one system in the US that's FDA approved, Michael Abramoff's system, IDX, digital diagnostics, I guess. It's that's approved for one specific camera. And there's recently been a second system, the EyDIA system, that's been FDA cleared for autonomous AI with a different camera. And so these things are just, camera specific. I'll tell you our experience in ROP is that, number one, up until relatively recently, there was only one camera, the RetCam, so it didn't matter. More recently, there are multiple cameras. And what we've been finding is that if you take one camera, you diagnose disease, you can train a system on that camera. You take a different camera on a model that's trained from the first camera, doesn't work. If you train the model on that second camera, it works on the second camera. And what we've been finding is that if you train a model with images from both the cameras, it then works on both of those cameras. If you train on A and B, it works on A and it works on B. And I think that one of the, there's that's one issue. I think that, Wei Yan, another variant of the question you asked is take a camera and switch out population. A Singaporean population, trained on a U.S. Caucasian population, trained on a different ethnicity population. We're finding that it's not as generalizable always as what I would have hoped. And so I think that's what I see as some of these questions. But we've specifically tackled that question with images by training on multiple systems, and we haven't done it on enough to really understand the generalizability. But I think this is really important.
Yeah, agree. Yeah. Tian, do you have any comments on that?
Yeah, I mean, my comments are the same, right? There are many challenges which Michael has listed. In fact, when I started looking at this field, when the first deep learning systems came up for diabetic retinopathy, now it's about 5 years ago, right? 4 or 5 years ago. We had a list of questions, and that list of questions has expanded and exploded. It's a lot of things. In fact, when we went into this field, we were asked by some people to say, what's there to do now that, the paper is out, the system is done, there's no need to apply for a grant. That was one of the reviewers' comments, essentially. But now you can see, right, you're looking at so many individual things, right? What is the gold standard? What's the delta? How do you incorporate other information? What do you do with different systems? How do you get, how do you generalize it to different systems and different populations, different age, different gender? I mean, everything is really up for grabs at the moment, and these are just isolated within the system. Now, then you're talking about the broader issues, which I think a lot of some of these scientists should work on it, and I think it's important to not just think about the technical people, right? The epidemiologists, the social scientists, the behavioral scientists. I think they need to work on some of those aspects, because the acceptance by physicians, by patients, by society, and then by healthcare providers, policymakers, the whole larger ecosystem. I mean, that part has actually not even been addressed, essentially. And I think that Mike's challenge, as you are aware, is addressing some of those kind of issues. Say, once you get a system, what are you going to do about it, essentially? How do you fit it into the healthcare system? That is a whole set of things that I think we need another team of people, not the technical people, maybe not even the clinicians, but, as I said, the public health and the social scientists. They need to look at some of these issues, essentially. They're quite critical.
Thanks, Dan. So, I'm very conscious of time. So one last question that I thought is actually quite important that Mingge has posted. The rapid evolution of AI adoption is going to affect the balance between the science and art of medicine. How do you view the generation gap between the ophthalmologists, and older ones are better worse with the descriptive, less quantifiable aspects, and the younger ones are better at interpreting quantifiable data, but maybe insensitive to the nuances not captured in the data? How do you optimize these differences? I think this is a very, very interesting topic to talk about.
Yeah, Dan and Mingge, I think that's an awesome question. And, one of the reasons that I got interested, and let me give an example if I could, just for a minute. One example that I got interested, example of why I got interested in informatics was that as a medical intern, I used to see patients where Mrs. Jones would be telling me, in that narrative history that, she was walking up the 3rd flight of stairs and she started to feel tightness in her chest and it felt like there was an elephant sitting on her chest. And I would write all that stuff down. But what I was really thinking is that we're going to admit you to the hospital and make sure you didn't have a myocardial infarction. We'll rule you out for MI. And I started to wonder, why can't we just say rule out MI? And then, and now we live in a world where, because of data and because of electronic systems, there are checkboxes that say rule out MI, chest pain, pressure, like that, and people practice medicine that way. And I actually feel like something has been lost in the way that I practice medicine compared to the way I practiced medicine, 15 years ago, 20 years ago when I first started. And to get to the point of what you asked, that actually concerns me. And it concerns me as somebody who helps develop these systems. Okay, are we going to contribute to this problem? And it also, as somebody who helps educate people, are we training a generation of patients of doctors who's lost those skills, especially if someday, because of the wonders of Dan Ting and Tian Wang and the rest of Singapore, that doctors are using systems to give diagnoses, and all that they have left to separate them is the ability to communicate with patients and elicit that nuance. So I completely agree that we need to have both of those things. And I think one of the challenges of the education process is going to be to teach concepts exactly like what is in that question and how important it is to do that. And in the US, it's just telling our trainees, you can't just copy that previous note and, push Control V, because that's not the way we practice medicine. And someday that interaction with your patient is going to be what separates you from the AI system, or what gives you added value to the AI system.
Yeah. Jen, what do you think? Like you're currently the Vice Dean for Duke and US students.
I don't. I think I'll leave the last words to Mike, and he said it very clearly. I think there's always balance, right? I think the balance between status quo, sticking to old paradigms that really should be changed, and yet not moving into new technology and new areas that is going to replace everything. I think the traditional practice of medicine, in which all of us, train as physicians, otherwise we should be not in this profession, needs to remain. At the same time, we should not shy away from technology that really helps our practice and improves patients' quality of life and the outcomes, right? So I think that balance is quite important, and I think for younger doctors, they're listening in. You need to be comfortable with data, with technology. These are the new fields, but do not lose fact that the patient in front of you, it's not really a mass of data, right? They are a person, and they do need that very holistic part of our care. And I think all of us, Mike, I'm sure knows this as well as all of us here, right? That many times we have no treatment except to comfort the patient and to give advice and to be really a listening ear. So I think that hopefully, reassures us that technology like AI is here to help us and will really not be a replacement in anywhere near, I think, for many years, many decades to come.
Yeah, I can't agree more. I mean, one of the fun thing is, could we even teach AI to teach a bedside manner, or like to teach the medical students to build the patient's rapport with the clinician? I mean, those are the very interesting topics that we can actually explore in another forum. So, quite conscious of time, and I think we have reached the end of this webinar. And Mike, thank you so much. It's already 1:30 a.m. in DC, and I think you probably go to bed now very soon. And really appreciate that you could actually make it this time. And we hope to see you in person soon, like sometime next year when the COVID situation has settled down a little more.